Hello and welcome. My name is Kathleen Ruddy. I'm the CEO of the St. Baldrick's Foundation, where we work with heroes for kids with cancer every day. Our guest today is Dr. Joseph Lubega. Dr. Lubega is a pediatric hematologist and oncologist at Texas Children's Hospital, an associate professor of pediatrics at Baylor College of Medicine. He's certified in molecular epidemiology, public health, implementation science, and as a certified physician executive. He holds several leadership positions focused on his ultimate career goal to improve the survival of children with cancer and blood diseases in low and middle income countries, particularly in Africa. To this end, he holds 4 additional positions, all international. One is at Texas Children's Hospital in their Global Hope program, another with the American Society of Pediatric Hematology and Oncology, also with Makerere University in Uganda and Muhimbili University in Dar es Salaam, Tanzania. Welcome, Dr. Lubega.
Thank you, Kathleen. Thank you so much for that kind introduction.
Well, hearing about all your roles, I am fascinated and a little exhausted and intimidated, but you are amazing, and I have so many questions to ask you. Thank you for being with us today.
Thank you for having me.
You are from Uganda, a developing nation that is really rich in talent, but whose medical training programs need greater investment. So given some real obstacles, what made you decide to not only become a physician and a researcher, but to go into pediatric oncology, one of the hardest and most challenging medical professions of all?
Well, Kathleen, that's a tough question. Tough because first, I cannot say I even ever dreamt of becoming a physician. I was the first to become a physician in my entire extended family. And in Africa, extended families are really extensive.
Mm-hmm.
I grew up in a very, very poor background, even for African standards. And I think as a child, all I cared about was living to the next day. At some point in my middle school, I, believe it or not, made an attempt at becoming a priest, a pastor. I joined a seminary, partly, I think, because they tend to be quite good schools that are inexpensive. But I didn't like it there. And my parents gave me a condition. They said, look, Joseph, if you really want to get to a secular school, just get very good grades and you're good to live. And I think that really motivated me to get outstanding grades my high school. And typically in Uganda, when you get good grades to go to university, people choose one of 3 professions, either law, engineering, or medicine. And I chose medicine. And I think my failed attempt at a career as a pastor still sparked that thing in me to closely want to connect with people and care for people. And, that's how I ended up as a physician. Now, the real memorable moment, though, when I had to make a categorical and deliberate career decision that I think has led me to where I am today, it was in my study of medical school, where during my clinical rotations, I met a very intelligent, charming 6-year-old girl from the slums of Kampala in Uganda who had cancer. And she slowly, hopelessly faded away in my face over a period of several months. And I tried all sorts of avenues to raise money for her care before I realized 2 things. One is that the man I raised couldn't and didn't save her life because the care services didn't even exist in the country. 2 is actually the man I raised for her wasn't a waste of my effort because while she and her family were fighting for her life in hospital, her family actually back home was starving, literally. So her mother actually used that money to buy food for her siblings back home and for herself. And this incident for me was more of an epiphany in terms of my medical career, because whereas earlier on I was a medical student absorbed in, just consuming knowledge, I kept asking myself, how is it that a disease or any disease cannot be cured or has no cure in any country? So I became really interested in research. 2 is I learned that I chose the right profession because I realized that being a physician is all about caring, and sometimes caring even to the point of where it hurts, but care we must. And lastly, I got hooked to working with children. I found them to be a fun bunch. So 2 years later, after my medical school, I emigrated to England with the explicit goal of becoming a pediatric oncologist. While in England, I did residence rotations in surgery, in elderly medicine, family medicine, in addition to pediatrics. And I eventually left and moved to the USA. Now, in retrospect, all that long, winding journey and what seemed to be diversions all serendipitously prepared me for a task I didn't realize would be the focus of my career today, which is trying to navigate the complex challenges that stand between children with cancer and blood diseases in under-resourced countries and the life-saving care they desperately need.
It's incredible. It's a fascinating journey, and it's interesting to see how you went on one path and there was definitely the hand of providence in your path. And I think as our audience will hear, they'll come to believe that themselves if they don't already. But it's fascinating. And we always say that in the St. Baldrick's world, everybody can be part of curing kids with cancer. And you may not envision it as part of your path, but you can have a very powerful influence, and you certainly are. So tell us, please, what are some of the key differences between childhood cancer in Sub-Saharan Africa and the US in terms of prevalence and survival? And do you see different types of childhood cancer there than in the US overall?
Yeah, Kathleen, much has been said and speculated about differences between childhood cancer in Africa or other developing countries and North America and Europe. But I think let's be clear, the really biggest difference is so obvious and has nothing to do with cancer per se. It's that children with cancer in Africa find themselves stuck in health systems that are extremely under-resourced to be able to help them in every or any aspect you can think of. Suspicion that they have cancer, referral, diagnosis, staging, treatment, monitoring, survivorship care, for the few who are likely to make it through all those preceding hurdles. So the lack of access to care is the key. That said, there are some differences in the patterns and types and curability of cancers. For example, thanks to research our team is conducting with support from St. Baldrick's Foundation, we are finding that children in Africa tend to have more difficult to cure leukemias, such as myeloid leukemia, than their US counterparts. Kidney tumors seem to be way more common in African children than the US, although that pattern is actually similar to the US, where Black children tend to have more kidney tumors. Then there are things like HIV-related cancers, such as Kaposi sarcoma, which we hardly ever see in the US due to the rarity of uncontrolled HIV in children in the US, but still happen not as frequently as previously, but still occurs in places like Africa. So yes, there are some differences that are likely related to the environment, especially the environment in Africa where there's a high prevalence of endemic virus infections that may predispose to certain cancers, and possibly African genetic ancestry. But by and large, our research demonstrates that the patterns of childhood cancers are the same in Africa as in the USA, and the most conspicuous differences are due to disparities in access to care. And what these disparities really mean is that less than 20% of children in Africa survive cancer compared to 80% that are cured in the US. And that's really the crux of the problem.
What you're describing really underscores the importance of working across borders, because cancer doesn't discriminate. Any child could be diagnosed with cancer, and we can move much faster in research if we're able to leverage what we can learn from every patient and make sure every patient gets that state-of-the-art care that we're so fortunate to have in abundance here in the US.
Yeah.
So what percentage of children in Uganda and surrounding sub-Saharan countries are able to access treatment?
It's around 10 to 20% only. At least in East Africa, around at most 20% of children with cancer ever receive definitive cancer care. And this is based on our estimates of the expected incidence of cancer based on numbers from US and Europe, which we think is an underestimation because there's lots of evidence that probably overall children in Africa are more prone to cancer. And then the concrete numbers we have of the few treatment centers that are extant or emerging in the region. So only 10 to 20% receive expert pediatric cancer care. And even for those, it's largely suboptimal care due to constraints in terms of equipment, supplies, personnel staffing, and this is not just for pediatric oncology per se, but across all the relevant disciplines and specialties of pediatrics, surgery, critical care, pathology, radiation therapy, transfusion medicine. So, and remember, these children in Africa and other low-middle-income countries comprise around 80% of the world's children with cancer. So the question to me really is, how do we deliver therapies that we already know to be effective to these children? And to me, that's really the grand challenge of the field of pediatric oncology today.
Well, you're describing also the fact that you're working with estimates based upon known indicators as well as kids who actually get diagnosed, but there are so many who probably never even get the diagnosis. Isn't that correct?
Absolutely. The majority of them never get the diagnosis, they never see an oncologist.
Mm-hmm. The things we take for granted sometimes. My colleague, Becky Chapman Weaver, who was fortunate to visit your program in Uganda, told me of a teenage boy she met who walked alone to Kampala from South Sudan for treatment. And the imagery that conjures up, and we have challenges here in a high-income country in getting to treatment, but I've not heard a story like that happening in the US. So what you share is very poignant. So St. Baldrick's came to know you, Dr. Lubega, when you received our first International Scholar Award back in 2013. And for our audience's benefit, I should say that these grants provide a sort of on-the-job training to researchers from low and middle-income countries. And the deal is, if you agree to a career in pediatric cancer research in your home country, you come to the U.S. for training, or the U.S. or Canada typically for training under a seasoned researcher. And while you're there doing your training, you're actually doing a project. So for the St. Baldrick's Foundation and Kids with Cancer, it's a multi-level win. But with that background, let me ask you a couple questions. First, what was your greatest challenge in coming to the US for treatment? I know you had been in the UK first, but what challenges or obstacles did you have to overcome?
Yeah. Certainly I experienced professional culture shock when I first came to the US. American medicine is very fast-paced, highly technology dependent. Many of these technologies often not available or routinely used even in Europe. It's extremely complex in terms of the levels of specialization and administrative layers that a physician deals with. And it requires a huge amount of sensitivity to multiple cultures and individual family preferences. But I think that diversity and the richness of it was kind of an immersion for me, and I think that's what I really needed for the kind of job I'm doing right now.
Well, you had a history, I think, of overcoming challenges. So you knew you could rise to the occasion. Not that it makes it easy when you're in it, but I think you probably had an innate confidence that you could do it. So you took the purpose of this grant, which was to get yourself trained to be a researcher in addition to a physician, and you did something very special and unique. Would you please describe that to our audience?
Well, I don't know if I took it a step further. I think I just did as you told me to do. That is, St. Baldrick's Foundation asked me to use this resource to build a team that will expand, accelerate, sustain childhood cancer research. that is impactful in Africa. So, with the support of Baylor College of Medicine and Texas Children's Global Hope Program, I returned to Uganda in 2016, and amidst conducting my research, built partnerships with the relevant government institutions, and managed to launch a formal 2-year pediatric hematology oncology fellowship program at Makerere University, which is one of Africa's topmost universities. And fast forward today, there are now 20 more world-class pediatric oncologists from across the region, including in Uganda, Kenya, Tanzania, Malawi, Congo, and Nigeria. And I think what we have right now is a fairly solid foundation for locally impactful childhood cancer research and treatment. And I think we should all be very proud of ourselves. St. Baldrick's and everyone that contributes to the mission of St. Baldrick's should really be very proud of themselves.
Well, we like to talk about goosebumps moments, and you've given us one, because the idea that in just under 8 years, you've gone from being the first pediatric oncologist in all of East Africa to now having 20 is absolutely an incredible accomplishment and achievement. And thank you for thanking the St. Baldrick's community for making that possible. But we believe in you, and you were the boots on the ground making it happen as well, and overcoming incredible challenges to do that. We know that that's just the start of meeting the need, and also of your work. For those in our audience who've just joined us, we're speaking with Dr. Joseph Lubega, a pediatric oncologist at Baylor College of Medicine and Texas Children's Hospital, and Makerere University and the Uganda Cancer Institute, and Muhimbili University in Dar es Salaam, Tanzania. He is a busy fellow. So, Dr. Lubega, spending as much time as you have in the US, I know you've heard the term bang for the buck. We love to use that one, and talking about getting as much as we can out of every dollar. And that's certainly a value that the St. Baldrick's Foundation shares. When I think of return on investment on our grants, few of them, I think, would have achieved what you have, or could say they've created the capacity that you have. How has the training that you got through your St. Baldrick's grant changed cancer in Uganda and the surrounding countries beyond the training of new doctors? How else have you been able to leverage those connections and the exposure you've had here in the US to advance treatment there?
Well, Kathleen, it has really been an amazing transformation. First and most important is that now over 2,000 children diagnosed with cancer every year in this region receive evidence-based care. Withstanding the numerous challenges that the providers and the families face in doing so, the survival of children has actually dramatically improved. And we are talking about over 70% of children alive and in remission a year after cancer diagnosis, where previously the majority were dead or abandoned treatment within a month or a few months. The other thing is that almost every one of the pediatric cancer specialists that we've trained has become a designated leader in their city or region's pediatric cancer centers. And they are really truly pioneers of that field in this part of the world. Even more exciting, which you hinted on in terms of accelerating these improvements, is that the teams are now multiplying themselves by, for example, establishing a new training program in Dar es Salaam in Tanzania, which is now training 3 pediatric hematology oncologists every year. And the teams are actually now starting to conduct research, sharing locally generated best practices and evidence with others, and forming really a professional community to support each other and sustain this. So I think when you think about this from the patient care, from the organization, or from the research perspective, it's really already transformative.
And for you personally, How did the International Scholar Award from St. Baldrick's and your training at Baylor and Texas Children's help you advance your career and develop your trajectory?
It was critical because this came towards the end of my uh, formal career training as a physician. That was the end of my clinical fellowship. And what St. Baldrick's helped me is that Baylor College of Medicine Texas Children's Hospital has become my really academic career home. Whereas my heart is really in Africa, my feet are grounded here in a Texas Children's Hospital and Baylor College of Medicine, where I hold a faculty position. And notably, obviously, Texas Children's Global Program has been and continues really to be a critical stakeholder in this endeavor, both in terms of financial investments, but most importantly in terms of expertise transfer. And as you know, Texas Children's is obviously one of the largest children's hospitals in the USA, and there is commitment at all levels to help countries with less resources build better pediatric programs. And like they say in Texas, thankfully, this is not the first rodeo for Texas Children's. They've done this before, especially with HIV over 2 decades. Very few children's hospitals or pediatric departments, have this level of commitment to the world's children. So for me, the help I received from St. Baldrick's to really kickstart my career here at Texas Children's has really opened up this whole new world and possibilities. And it's really an enormous privilege for me to be part of all these institutions.
Do you feel that the increased capacity that you're building there in Africa, particularly with new pediatric oncologists and all the knowledge that they're bringing to it and the ability to participate more in research, do you find that that's helping the government or health ministries or other entities take a larger interest in pediatric cancer or other investments in the health of Africa's children?
No, absolutely. Yeah, absolutely. I mean, as we all know that, governments tend to move change at a much slower pace than, private enterprises. But I think what we provided is that spark to demonstrate that, one, this can be done, and this is how it can be done. And yes, in all the countries where, we've trained pediatric oncologists or where Texas Children's Global Program is involved, there is enormous support and involvement by the local ministries of health, which is very critical because in almost all these countries, their health systems are largely operated by the government. So it's very important that there is, that level of engagement and involvement.
Mm-hmm. So you have these hugely important roles in 3 countries, US, Tanzania, and Uganda. I kind of suspect that since your reach now through your program and all the oncologists you've trained, it actually spans multiple countries. You have more goals for Africa. What would you share some of your vision, your long-term vision with us?
Yes. So I think 2 key goals that I feel are the most critical to maintain the momentum or even accelerate what's already going on. One is the need for mentorship and support of all these young pediatric oncologists. These are young specialists in the field that need all the support and mentorship they can get. As you noted, providing pediatric cancer care is challenging enough, even the best of settings or facilities. These folks are doing it in very severely constrained circumstances. And, it's so important that we provide them all the support to do their job and make sure that all the challenges of the field don't take a toll on them and they abandon their mission. So I think mentorship, facilitation, supportive networks are very critical for them. The second key goal I would think of is uh, related to the previous one, which is building cooperative group networks for these community of fledgling pediatric oncologists in Africa, so they can share experiences, have a common voice to advocate for the children, support each other, share clinic and research resources. We know how much, for example, groups like Children's Oncology Group have impacted pediatric oncology in the US. So I believe, the stage is set now, and the key to keep gaining momentum or even accelerating for Africa in this area is to build this connected community of pediatric oncologists.
So, as I mentioned a few minutes ago, my colleague Becky Chapman Weaver attended the Makerere University graduation of your first class of graduates in Kampala and visited the hospital where kids are treated, and also attended the annual Children's Survivors Day camp. And she was so moved and shared it with all of us in the foundation. She was so moved to meet so many children who have a whole lifetime ahead of them because of your work there. And she spoke of how passionately you and others on staff in Uganda care about each child in treatment and the survivors, and your ceremony that day to honor the children lost during the prior year. What would you like the audience to know most about your work in Africa, and as well as how they can support it?
Mm-hmm. Kathleen, it was lovely and an honor to have Becky join us, all the way from California and Uganda. I think it says a lot about the people who work in St. Baldrick's Foundation, particularly since she self-sponsored for the trip. I would say there are so many precious things that go on in these places. I mean, it's all the triumph for those who survive and the unimaginable sadness for the children that die. I would say for me, three things that are critical. And I think these are true for any time a child has a terrible illness or disease, but it's more palpable when you're in settings such as Uganda. And one is that on a daily basis, you witness providers and supporters like you all who go beyond, the call of duty to save these children. Two is that you witness families that sacrifice everything for the love of their children, and you cannot even fathom what, whichever way that disease process ends, what it means to them. And three is the children who are thrown to the front line of one of the roughest medical battles, and they can't even wrap their mind about what's going on, and they just trust that between us and their mom and dad will figure it out. So and I think that's the job that's cut out for us, is we must figure it out for these children. And you see these every time you walk into these gigantic wards in Africa, and you try to wrap your mind around how can you really help these kids. So in terms of support, I would say these children need a lot of our support. And I think, to me, the key is that in the settings like Africa, a dollar can really go a long way and make a huge impact, as we just demonstrated with the St. Baldrick International Scholarship and what we've been able to achieve and what has triggered. One of the things is we need funding for different kind of research that focuses on bridging the gap between therapies that we know work and access to care. I think the field of pediatric oncology, whereas in one aspect it's in pole position for bringing new scientific discoveries to the bedside to cure patients, in Norway it's also in pole position for an example of a field where the majority of the people who need that therapy don't have access to it. And I think there's a lot of work we can do in that regard, to do research that helps deliver care to these patients. The other aspect to this is that again, like I said, you have all these young pediatric oncologists in Africa, South America, and around the world. They are starting to form communities, and any support that can help them build cooperative research groups, and which we know has been a key pillar of success in North America and Europe, is very important, because it's not just the individual research project that will be done, but it has that effect of forming a family, a professional family, a team of advocates or researchers or providers that will provide for children in these countries. And to me, I'm certain that this is the next frontier of pediatric oncology. I'm sure there are many new paradigm shifts that lie ahead if we invest in pediatric oncology in these countries. Because right now, everything we know based on the 20% patients we see in North America and Europe. The bulk of the kids are out there.
Well said. You've given us so much to reflect upon, so much to be grateful for. I want to thank you, Dr. Lubega, and your team for the incredible work you're doing to train pediatric oncologists in Africa and treat children with cancer in Africa more effectively, and for allowing the St. Baldrick's community to be part of that. We're incredibly proud of the work that you've done, and we wish you Godspeed in doing much more over the coming years.
Thank you, Kathleen, and thank you for having me, and thanks for all the work that St. Baldrick's Foundation does.
And thanks to all of you, our audience, for tuning in. Here are 4 things you can do to help children with cancer in Africa this holiday season. 1, learn more about it. Visit the St. Baldrick's website and click on the blog and type Africa in the search box, and you'll see lots of articles about Dr. Lubega's great work and all the outcomes of it. 2, please share this interview and any of the blogs about Dr. Lubega and his work on your social networks. 3, make a gift to support more great work like this at stbaldricks.org. And 4, mark your calendars for January 12th at 9 a.m. Pacific, noon Eastern, for our next episode when we speak with Mike Fiscus, a more than decade-long volunteer and St. Baldrick's event organizer and Shavee. He's going to talk to us about how volunteering for the St. Baldrick's Foundation helped advance his career. From all of us at the St. Baldrick's Foundation, we wish you a love-filled and healthy holiday season. See you next year.